Good morning, welcome. I'm the Chief Exec of Royal Voluntary Service, Catherine Johnston, and thank you so much for freeing up some time this morning, an hour, to come and listen to some of the research that we've been doing on volunteering and tackling health inequality. Today I'm going to be joined by the researchers of the report who I'll introduce in a moment, and we've got a panel who will respond to some of your questions later on. We're expecting about 75 to 100 people to join us, which again is phenomenal in these very busy times where everybody's diaries are very congested. So the reason I'm really proud of this report is because it's the third report in a series that we have been producing around volunteering and kickstarting a volunteer revolution. So the first two were one that we published last year about volunteering in integrated care, and that had a particular focus on the pandemic. The second was later, earlier this year, and that was about volunteering and the power of volunteering in improving people's social mobility. And again, really compelling evidence about the power that volunteering brings to individuals and communities in terms of health and well-being. So this one is particularly important because this one looks at the importance of social connectedness and how volunteering as a public health intervention and volunteering as a health and well-being, almost social prescription, actually can empower people to stay well or to improve their health and well-being. It also looks at the correlation between volunteering, health and well-being, ONS scores, health inequality, Sir Michael Marmot's work on tackling inequality, and obviously the pandemic, which has continued for an extended period now, both in terms of the crisis and now is looking to recovery, means that we've really got to focus on very practical solutions to how we can help our nation recover successfully from the impact of COVID and the resultant deterioration in people's health, both physically and mentally. So I'm going to be joined by Dr. Kimberly Smith, who is from Surrey University, who has worked alongside Dr. Alison Smith, who is a member of the team at Royal Voluntary Service. And they have spent quite a bit of time interviewing, looking at the evidence, and are going to both present today on their findings. We will then be followed with a panel which would include Sam Ward, my lovely Sam Ward, who's my Deputy Chief Exec at Royal Voluntary Service and Director of Services, who will be known to many of you. And Fiona Longhurst, my Director of Comms and Marketing, she will be hosting us today and making sure we all stick to time. I'm going to pass over to Dr. Kimberly. I would make the point that at this point that whilst it's Dr. Kimberly Smith and Dr. Alison Smith, they are not related. It is pure coincidence, but it has made my introducing much easier today because it's Dr. Smith's. So over to you, Kimberly, and I hope people enjoy listening to the findings.
Okay, so thank you so much for that lovely introduction, Catherine. So I'm here to tell you a little bit more about an evidence review that we undertook to look at the link between social relationships with health and well-being. So we all know that our social relationships are really great for keeping us happy and maintaining our well-being. But alongside this, there's an increasing body of evidence showing us that our social relationships can impact our long-term physical and mental health. So what the Royal Voluntary Service tasked me with doing was to come along and look at all this evidence and present it for the report. So I did that, but one of the first issues that I came up against was just the myriad of ways in which people define and look at social relationships. So researchers broadly are telling us that having good social relationships is good for our long-term health, but poor social relationships is bad for our long-term health. But what do we mean by good and poor social relationships? And how can we bring together all of this evidence in a meaningful way? Well, to help me do this, I looked to the work of one of the world leading experts in this link between social relationships and health, Professor Julianne Holt-Lunstad. And Professor Holt-Lunstad suggests that there's three main ways in which we can look at and categorise social relationships. We can categorise them by the structure that they have, by the function that they play in our day-to-day lives, and the underlying quality of our social relationships. So I'm now going to go through these one by one and just talk about what we mean by good and poor relationships in each of these cases. So when it comes to structure, simply put, bigger is better. The more social relationships that we have and the more diverse our networks, this is considered to indicate better social relationships. So poor structural relationships, that's things like being socially isolated and not necessarily having a very large social network, whereas good structural relationships are all about large and diverse social networks with lots of social activities. When we look at relationship function, better functional relationships are those that better meet our needs. So poor functional relationships are indicated by things like a lack of social support and feeling lonely, whereas good functional relationships are indicated by having lots of social support with little or no loneliness. Then when we move to quality, poor quality relationships, that's when we have a lot of issues within the relationships that we have, things like strain and conflict, whereas with good quality relationships, we wouldn't have so many of these issues. Now, again, this is potentially quite a lot for us to get through for this evidence review. So what we decided to do was focus more on research related to the structure and function of our social relationships, because this is where we felt volunteering interventions might be having an impact. Okay, so once we'd defined the social relationship side of things, then it was deciding which health outcomes to look at. When you look at this body of evidence, there's so many different health outcomes that people are looking at, it's actually pretty overwhelming. So what we decided to do was focus on 5 of the health outcomes that we have a lot of evidence built up around. These are cardiovascular disease, dementia, common mental illness, mortality and suicide. Now, alongside this, we wanted to make sure that we presented the best quality evidence in this evidence review. So we focused on 2 main things here. We focused on what we call a longitudinal study, where we can look at social relationships at baseline and then follow people up over the long term to look at how their health is affected over time. So we looked at those kinds of studies, and we also focused on a kind of evidence review called a systematic review. That's just a fancy word for, it's a kind of review that us researchers do where we look for all the studies that have answered a very specific question. And this kind of evidence review, a systematic review, is thought of as being one of the best kinds of evidence that we can use for public health decision making. So what did we find? Well, we started off with cardiovascular disease. There was an amazing systematic review done in 2016 by Dr. Nicole Valtorta, which showed us that both poorer functional and structural relationships were linked to having a higher risk of cardiovascular disease long term. But interestingly, more recent longitudinal evidence seems to be suggesting that it's more functional rather than structural relationships that predicts cardiovascular disease, in particular loneliness. So in general, poorer functional social relationships are linked to around a 30% increased risk of developing cardiovascular disease. When it comes to dementia, having poorer structural and functional social relationships is linked to between a 25 to 60% increased risk of developing dementia and or cognitive decline over time. Common mental illness, poorer structural and functional social relationships are linked to a greater risk of developing both depression or anxiety over time. And when it comes to mortality, having poorer structural and functional social relationships is linked to between a 25 to 30% increased risk of mortality over time, and poorer functional social relationships has also been shown to predict later suicidal thoughts. So that tells us what the existing evidence base is telling us about how our social relationships are linked to our long-term health. But I was given another task by the Royal Voluntary Service, and this was to explore why we as researchers think that our social relationships might impact our long-term health. So I went to look at what researchers think might be the main reasons explaining why poorer social relationships might lead to poorer long-term health. And I grouped these broadly. So first off, we have biological explanations. There's actually quite a lot of evidence now that having poorer social relationships is linked to biological things happening within our body. This includes things like higher levels of bodily inflammation, higher levels of stress hormones, higher blood pressure and higher blood sugars. All of these biological factors put us at a higher risk of poorer long-term physical health. We also have behavioural explanations. So people with poorer social relationships have been shown to have some worsened health behaviours, in particular poorer quality sleep and less physical activity. Both of these health behaviours have independently been linked to poorer long-term physical health. We also then have psychological explanations. So people with poorer social relationships, this directly can impact their well-being in terms of lowered well-being, lower life satisfaction, higher levels of depressive symptoms, and also a higher risk of common mental illness. All of these psychological factors, again, have been linked to poorer long-term physical health. Another series of explanations that researchers have relates to stress. So for some people, it's possible that the worse the social relationships that you have, the greater a source of stress this could be for an individual. Stress in and of itself has a huge and potent impact on us psychologically, biologically and behaviourally. And indeed, stress itself has been identified as a major risk factor for worsened long-term physical health, in particular chronic or long-term stress. Now, at this point, something that's worth noting is that our social relationships are really important in helping us to cope with stress and deal with day-to-day stresses in our lives. When we experience a stressful life event and we have people around us who can support us with that, that helps to dampen down the impact that stress can have on our long-term health. Also, another thing worth noting is that there is no one magical explanation here for why we as researchers think that poorer social relationships are linked to long-term health. It's probably different factors for different people. So the take-home messages from our review: having good and supportive social relationships could benefit our health and well-being, whereas poorer relationships are linked to a range of poor health outcomes. We've seen there's a load of different ways we can define social relationships, and it's possible different kinds of relationships could have different relationships with health. And as researchers, there's a number of reasons we think social relationships could be linked to health. They're complex, multifaceted, and there is likely no single explanation for why we as researchers think these two things are linked. So I'd just like to thank you all for that, and I will now hand over to Dr. Alison Smith, who's going to speak with you about the survey findings and recommendations from the report.
Thank you, Kim. That was brilliant, and a great sort of synopsis of the literature. As you said, it's ever growing and expansive, but that was great. What I'm going to do, following on from Kim's literature review, is over the next 15 minutes present findings from some new research that we did. Which hopefully sort of sets the context for some of what Kim was saying around the literature review. And then I'll set out some recommendations. So what can we do about this? How can we take this forward as we look forward to recovery? So the past 20 months, we've frequently heard the phrase that we're all in it together. And while at a simplistic level, that is true, we certainly have not experienced it in the same way. And the findings of this survey very much speak to that. So this survey is very much a snapshot of where we are both as a nation, but across a range of different neighbourhoods. Let me just quickly share with you just a bit of background and context for the survey before I move on to the findings. So we surveyed 2,500 individuals. It was UK-wide. We surveyed people across a range of neighbourhoods from the least deprived and the most deprived, using the index of multiple deprivation. The survey findings were then weighted to reflect the UK population, so in terms of age, ethnicity, social class, and the survey was done in September. Now, the findings that I'm going to present to you today are predominantly, not exclusively, but predominantly looking at the 10% least deprived versus the 10% most deprived areas. Because actually, when you looked at the data, this was where the greatest sort of differences were found. So the survey that we did focused on predominantly 3 areas that we were interested in. So people's social relationships, their perceptions of health. And then we were interested in people's voluntary activity in terms of, is volunteering, as we know from the literature, potentially a mediating feature, a moderator in people's perception of social relationships and health and well-being. The next few slides, I'll present some of the data in respect to social relationships. So those living in the 10% most deprived areas reported actually more frequent contact with friends and family. But interestingly, this did not necessarily translate into greater levels of meaningful social connections. And again, this might speak to some of the structure and sort of function of relationships that Kim highlighted in her presentation. So what we found when we asked the question, to what extent do you have people to call on if you want company to socialise? So there was an 11% difference between those living in the 10% most deprived areas and the least, in respect to those saying that they had lots or some people that they could call on. And I should say the numbers in bold actually indicate statistical significance, which means they're not down to chance. So these are significant scores and differences between the most deprived and the least deprived. We were then interested in questions on neighbours. So how often did you chat to your neighbour? And this is more than, just wave and say hello to. So those living in the 10% most deprived areas, 16% said that they never chatted with a neighbour versus 8% in the least deprived. And then we were interested in, well, why? What were the reasons potentially underpinning that? What insight could we gain from that? And so these statements were the most sort of common statements. So didn't trust or get on with neighbours. So that was 12% in the most deprived areas versus 5% in the least. They were new to the area, 9% in the most deprived and 3% in the least. And this might represent maybe higher population turnover in sort of more deprived areas. And then thirdly was people just don't speak to one another. So 18% in the most deprived versus 10% in the least. And this could have to do with issues in the built environment, such as lack of parks or community centres that perhaps maybe underpin some of these findings. Then we looked at companionship. So how often do you feel lonely And again, we see a difference between areas, so a 13% difference between areas reporting often, always, or sometimes. And again, those numbers in bold are those where there's a statistically significant difference, so it's not down to chance. You know, huge divergence between those two areas. And as a comparison, if you look at, say, Office of National Statistics reports on loneliness, approximately they find, you know, 25% or 1 in 4 report often or always or sometimes lonely. So that gives you kind of a comparator of where this sits with the general population. This I found quite interesting, sort of this question. So we asked, to what extent have you lost or gained confidence socializing with others since the start of the pandemic? And there was absolutely no difference across areas, maybe 1 or 2%, but marginal. Across the board, we found 1 in 3 stated that they had lost confidence versus 1 in 12 stating that they had gained confidence. So this, you know, again, might a feature of the pandemic. It's probably not surprising in that the length of the pandemic, the lockdown and various social distancing measures have probably had a wider behavioural impact on the population, and also something we should keep in mind as we look to recovery. Then we looked at what aspects of people's health aspects of their health they felt were better or worse than 12 months ago. And in this data, what I've chosen to present is essentially kind of the extremes of the answers. So is it much worse? Is it much better? Because the extremes is essentially, that gives us an indication of what's important in terms of public services as far as demands, but also us as a charity, what demand can we expect, and what resources need to be in place to address these various issues. And while these numbers actually in percentage terms look very small, when you aggregate it up to population level, we are talking about some fairly sizable numbers. So 11% equates to 11 million people over the age, 11 equates to 6 million people over the age of 18 that feel that their mental health is much worse. And again, huge, huge concern in terms of provision of public services, but also what we need to do as far as look ahead to recovery. So those in the most deprived areas report much worse outcomes in respect to mental and physical health. But when it comes to general well-being, there's actually not a statistically significant difference. And this might just reflect sort of the wider mood of the nation and sort of poorer well-being sort of across the board. And this is echoed by some of the ONS data, that actually well-being still remains lower than it was pre-pandemic levels. So I think this gives us sort of a good indication of current and future demand in these areas. The next aspect of the data that we wanted to look at gives sort of a great insight and further supports some of that sort of rich data that Kim has pulled together. You know, we wanted to understand, well, are those who volunteered any better off? So when we cut the sample by those that volunteered and didn't volunteer, approximately 16%, or just over 400 volunteered. So within those sample of who volunteered, about 1 in 3 stated they had an underlying health condition, and there were equal numbers of volunteers distributed across the least and the most deprived. So just to say, the results that I'm going to present in the next slide are not down to the sample being healthier or more affluent. Firstly, apologise for the busyness of this slide from a data perspective. This is a dream slide for a researcher. But I appreciate, you know, this isn't a presentation about death by PowerPoint, but I think it's really important to see the data side by side. So we looked at all of the data, so volunteers versus non-volunteers, the entire sample, and then looked specifically at those in the most deprived areas. And the findings are incredibly encouraging. So those who volunteered appeared better off in respect to all of the key variables we were interested in. So those that volunteered chatted more with their neighbours. They socialised much more. They gained confidence in socialising with others since the start of their pandemic. And both their mental, physical and general well-being was much higher. Now, the findings presented in this data are not in isolation. So there's been a number of really impactful studies that has been done during the pandemic that's looked at those that step forward and the health and well-being benefits of that, and non-volunteers. And I don't know in this webinar if there's anyone from the Belong or University of Kent research. Brilliant study, which again looked at those that stepped forward and those that didn't. And they found that those that stepped forward to volunteer were protected by some of the worst effects of the pandemic compared to others. So in the University of Kent and Belong research, they found, you know, greater people that volunteered had greater connection to family. They were more connected to their neighbourhood. They were also less likely to see their area as deprived, and they had greater levels of trust and subjective well-being. And while these findings can't conclusively say that volunteering is driving these impacts, we know from previous study that there is a causal link between volunteering and well-being. And now I'll bring us on to some of the recommendations, some of the 4 recommendations of the report. And I'll just briefly go through sort of each in turn, and then we will move on to the video. But to say, so based on the data, we have set out these core recommendations for what we can take forward. So the need to recognise volunteering as a public health intervention. So during the pandemic, we have been able to study volunteering in ways that we probably haven't been in the past because of the volumes of people that stepped forward. So we have been able to really understand the impact of volunteering, and some of the data collected by the London School of Economics on the NHS Volunteer Responders Programme found a causal link between volunteering and greater well-being and belong to community. And there are a number of sort of practical ways that volunteering can be recognised as a public health intervention. So social prescribing link workers could play a vital role here as far as critical touch points for local residents or trusted agents. Volunteering could be used as a social prescription in its own right to drive better public health. And we know that volunteering has double health benefits, in that by helping others in need, we're also helping ourselves. And critically, partnerships will be important as we move forward. So the public and business sector can play a bigger role than they currently do. Oftentimes employee volunteering is not very ambitious, and I think we can be more innovative and creative in this area, because volunteering in a strong civil society is not just the remit of the voluntary sector. It's really critical to a well-functioning public sector, as we've certainly seen through the pandemic and the support of the NHS, and also to the corporate sector in terms of employee health and well-being. And then I think there's a need certainly to focus on those areas that perhaps were exposed in the pandemic in terms of differences in geographical areas in terms of kind of social infrastructure and resilience. So some areas have been highlighted by the all-party parliamentary group on left behind areas where there's a lack of charitable funding, charitable activity, which has disadvantaged some of these communities more than others. And as we go forward, we need to correct that. And some of the vehicle for doing this might be the recently launched Shaping the Future with Volunteering, which is a group of 24 volunteering organisations that have a remit around supporting all communities and ensuring the benefits of volunteering are more equally enjoyed. And then finally, building volunteering into the Levelling Up agenda. So as the government looks to develop the Levelling Up agenda and ahead of the publication of the white paper, we really need to ensure that this agenda goes beyond a single focus on economic productivity. And as Kim and I were writing this report and looking at the literature, I was reminded of a book that I read about 10 years ago called The Hidden Wealth of Nations by David Helpin, and it was relevant then, and 20 months into this pandemic feels even more relevant. So this looks at the paradox between happiness and economic growth, and the paradox in that while richer nations tend to be happier, economic growth doesn't increase happiness. What increases happiness among citizens is how we relate to each other. So the love and friendship we have for each other, the levels of trust in our community, how safe we feel. So the wealth of nations is in fact not monetary. And as David explains, the extent to which citizens get along with each other independently drives both economic growth and well-being. Therefore, any notion of levelling up or building back better, building back fairer, should have a focus on strengthening this hidden wealth, and volunteering is a vehicle for achieving this.
We're going to come to some questions, and you have been busy putting your questions into our live Q&A, so thank you for those. And I wanted to kick off. I also want to just say a couple of things. Sam Ward, our Deputy Chief Exec, is joining us on the panel. She looks after all the services at Royal Voluntary Service alongside all of those you've met already this morning. That's fantastic. Welcome to you, Sam. We're also going to be recording this presentation for you, so you'll be able to get to view this again and share with colleagues. And we'll be sending around the report to all attendees on Thursday when our report officially launches. So you're getting a bit of a preview today, and we're delighted to share it with you. So without further ado, I'm going to come to take some of these questions that have been pouring in. And the first one I wanted to ask, and I'll take to Catherine if I may, is about this tantalising idea of volunteering being viewed as itself a public health intervention. And I want to ask Catherine how that can be embedded most effectively, in her opinion. What can be done to make sure that the best advantage is taken from what appears to be a fantastic opportunity? Catherine.
Thanks, Fiona. So as the Chief Executive of Royal Voluntary Service, sort of the clues in the title, so we believe passionately about the role that volunteering plays in making a deeper, more diverse civic society. But I guess what is encouraging about all of the work that Kimberly and Alison have just presented is that actually there is real solid evidence about the value that volunteering brings to people's health and well-being. And therefore, I think we have to look at it from a very practical perspective. If we go back to Michael Marmot's work, 10 years of looking at health inequalities in a number of areas, that research and the interventions that were made were very powered by money. And actually 10 years on, when Michael very bravely published the very disappointing results of the 10-year longitudinal study and work, and it was brave, and he is an absolute hero of mine for doing that, is it demonstrates that this is about people power, and it's about individuals, and it's about how you bring individuals together collectively in communities to actually improve the life of themselves individually, but also the collective. And I think the pandemic has powered that and shone a light again on how we do that. 12.4 million people stepping forward, 4.6 million for the first time, 3.8 million of those 4.6 million saying we really want to volunteer again, despite the fact this was our first time and it was in really difficult circumstances. You know, that is a massive prize. So the first thing is all of us in volunteering have to try and avoid the temptation to go back to where we were pre-pandemic, because the landscape of volunteering has changed, and I happen to think it's changed for the better. And I think it's shone a light on the importance of volunteering and the diversity and the inclusion that brings when we get it right. And I don't think that volunteer involving organisations and or infrastructure have all the answers. I think some of the public and private sector also have, and the state have some of the answers. But actually, let's construct volunteering in all of our planning. So let's make sure in the Levelling Up white paper that volunteering is attributed as part of the solution. And not necessarily part of the problem, that we as people already involved in volunteering strive to actually look at the changed landscape, look at volunteer roles, look at different types of volunteering. You know, some people have got really sniffy about micro volunteering, which is like task-based volunteering. You know, it drives me mad. Who are we to predetermine that individuals don't get an awful lot out of it from their physical and mental well-being for what somebody said to me the other day was sort of Instagrammable volunteering? And I was fuming, because actually we've got to stop putting judgments upon the types of volunteering. You know, whether or not you are shopping for a neighbour, or whether or not you are volunteering in my old organisation, Samaritans, for 16 hours a month, or lifting someone out of the sea with RNLI as a volunteer, or you're a special constable or whatever, you know, it's good for people to be able to step forward and to work alongside other people and to be socially connected. And therefore, I think in social prescribing, you know, through the new Social Prescribing Academy and the other arrangements in Wales and Scotland, you know, we need to be building this in as part of public health interventions, and not in a paternalistic way where we're saying, you know, this is good for you, therefore you must do it. But actually, all of the evidence during the pandemic has demonstrated if you're living with a long-term multiple health condition and you were living with it pre-pandemic, but you were enabled through people creating really meaningful volunteering roles that you could do either from home or with your limited mobility or limited access to spaces and places, not only were you contributing to society and your local community, but also you were less lonely, you were engaged, you had more confidence, you had a purpose, and therefore you have fared better during the pandemic than all of those other people living with long-term multiple health conditions who weren't volunteering. So there's, I think we've got to work together to create a whole matrix of volunteering opportunities and understanding that allows everybody to benefit from the value that volunteering brings.
Thank you, Catherine. That's great. And I've got a question here actually, which links in some ways to that, about one of the attendees today says that they grew up in one of the most deprived areas of the country, and actually they found that people did things for each other, never classed as volunteering formally, but it was definitely that sort of sense of mutual support. They always looked out for each other. But do we think that the lack of social housing, community centres, decline of physical meeting spaces, like, for example, the working men's clubs, have had an impact on people's health? And I wondered whether Dr. Kimberley would like to come in on that one. Is that something that you think has a relevance, Kimberley?
So the lack of spaces to undertake social activities, yeah, definitely. I mean, there'd be no question in my mind that a lack of spaces where we can engage with one another is going to mean we can't engage meaningfully with one another anymore. And I don't know, I'd also pose that question to Alison as well, because I think she might have some interesting thoughts too.
So yes, we actually, some of the data, I didn't present on that today, actually did ask people about amenities in their local area. And as you look across the index of multiple deprivation and communities from least to most deprived, Those that are most deprived do tend to have less sort of amenities, like community centres, parks, which is maybe driving sort of, you know, that those kind of important things that are in the built environment can kind of drive and encourage, you know, people, communities to come together, or they can also be a barrier for that. So there's definitely sort of something in that.
Great, thanks. Thank you, Alison. And another question, if we can stay with you, actually, around whether there was a difference, and I don't know that we looked at this, whether there's a difference between the experience of having a sort of virtual volunteering experience versus an in-person volunteering experience. And I know that as part of our work with NHS Volunteer Responders, we've had a lot of people been doing check-in and chat phone calls, haven't they, with people, which has been remote. But I think the data has shown us that that's been incredibly beneficial for both parties, both the volunteer and the beneficiary. Did you want to comment on that, Alison, as well?
Yeah, so actually that evidence came out in the data that was done by the London School of Economics, which looked at NHS volunteer responders and looked at the particular tasks that volunteer responders did, and actually the volunteer role that drove the greatest impact in well-being was the check-in and chat role. So that had, you know, compared to, I think, the next one, which was maybe transport, had the largest effect size in terms of well-being, because it probably speaks to that connection between people, rather than maybe, I mean, shopping is just as important, but those opportunities that allow people to kind of meaningfully sort of connect and chat has the greatest impact on well-being, according to the LSE findings.
Thank you. And a question here, and I'm going to bring to Sam, if I may, which is about the confidence issue. So as we're trying to sort of include more and more people in volunteering, is confidence potentially a barrier for people perhaps from areas of that are more socially deprived? And what could we recommend could be done among organisations to reach and support people from those backgrounds to volunteer, and to make it as easy as possible, I guess, to step in? Do you have any thoughts on that, Sam?
Yeah, I think that absolutely can be a barrier, but I think it's fairly easily overcome. I think we're all in the sector really used to being as inclusive as possible within our places and spaces, and I think there's a lot of different types of approaches that you can take to sort of get somebody's first step through that door, if you like, towards volunteering. So whether it's the we have this sort of invite a friend to come along and have a look at what their volunteering experience is like and how that is, whether it's a referral from a GP to say just go along and have a chat, where there's no great pressure on anyone to do that. But I think people often find really quickly, once they get into a volunteering role, that they have so many relevant and really important skills to give to that they never would have thought that they had, and they don't often realise how important the softer skills are and the experience that they bring to the role and to their community to help. They often think about skills being a professional kind of offer that you bring, and mainly that's not the case. That's what I would say.
Thanks, Sam. And one of the recommendations in the report is that there should be, we should be drawing on the corporate sector and government, working with civil society to support this. One of our attendees is noted that the pandemic's created many losses of jobs, and those nearing the end of their careers but not ready to completely retire should perhaps be encouraged to volunteer. I think we'd applaud that. For, what can be, should this be encouraged? Is there a moment now that we should be inviting those that have perhaps decided, and I read in the paper this weekend actually that there had been a lot of people taking the decision during the pandemic to perhaps take early retirement. Is this something that we should be opening up as a pathway, Catherine?
Well, yeah, obviously. But I don't think it's just about people who have made different life choices as a result of the pandemic. I think it's across the board. So I think it's incumbent upon all of us who have got volunteering at the forefront of our thinking, both public, private, state, and voluntary, to actually help play forward the sort of the pandemic phenomenon. So, you know, many businesses that we've worked with, I think we worked with about 250 businesses at the peak of the crisis, just within Royal Voluntary Service. And there was that adrenaline rush, and there was the what can we all do? We're all in it together, as we were saying at the beginning. But, you know, what I would encourage people to do now is not just sort of go back into the shadows, is to say, OK, if the power of volunteering, because we're all in it together, was so powerful, you know, 1.3 million volunteers standing alongside the NHS. In England, there are 1.3 million paid members of staff of the NHS. I mean, that is the size and scale of the volunteering effort. And unlike for everything else, you know, COVID has sort of exacerbated, you know, all the bad stuff over the last 20 months, with the exception of volunteering. It has been a real leveller in communities. So I've been out and about, going to lots of areas where we have services in particularly deprived area, you know, deprived parts of the UK, and I am seeing volunteers who would never ever have come out into their community, but because we were all in it together and COVID, you know, affected everybody, they felt able to. They've had the confidence to stand alongside other people who they didn't see any connection with. So I think we've got to work with the state. So with Levelling Up, with Build Back Better, with DCMS and their vision for volunteering, you know, Danny and Michael Gove and Andy Haldane on the Levelling Up agenda, to actually make sure that within our public services and within our communities, that we're joining up, we're putting volunteering front and centre. You know, historically, it's been this lovely sort of purvey of the rich and famous, or the rich and affluent, or the early retired. And actually, if we're going to get through recovery for COVID, we've all got to still be in this together, and therefore it's in everyone's best interest who have opportunities to plan to embed volunteering to do so, because not only will that help us to keep people better, better sense of well-being, improve their health and physical fitness, you know, people with long-term multiple health conditions waiting for operations, we want to keep them as healthy as possible, right, until they can have their operation, which is delayed. Or somebody who's waiting for bereavement counselling, we want to make sure that they're connected in a way that means that their bereavement doesn't actually mean that they deteriorate massively while they're waiting for a service. You know, there's all of those things at play now. And actually, only if we work together to plan and embed volunteering across all systems, all processes, all thinking about money, and we look at the inequalities and where we need to target the most, because that's where the most difference can be made, is we won't, you know, we won't make any gains. And I'm afraid that, you know, the spirit of 2021 will be lost. For me, let's not replicate the Olympic and the loss of that legacy. Let's actually play forward 12.4 million individuals who've actually given huge amounts of time and of themselves to help us all get through.
Thanks, Catherine. This last question, which is specifically about social prescribing, and Sam, if I may come to you about that, you know, how is RVS looking to embed volunteering and its health impacts into social prescribing agenda? It's obviously something that, you know, hopefully could have a huge impact on so many people. So what plans do we have there, Sam, at the moment?
So we've currently got a partnership with NHS England and also with the National Academy of Social Prescribing that we're working on at the moment. And it's how we can help really good pockets of great practice that go on in all our communities by national or bigger regional organisations helping to support them and take the skills and experiences they have to help them play that forward and basically lift and shift and spread that good practice. So that's absolutely fantastic for participants of those kind of different services that are available, and it'll help us to fill in those gaps within the jigsaw puzzle, as I call it, in each community where there's something missing, and we already know how to do that really well somewhere else. But obviously, the more of those opportunities there are in services, the more volunteering opportunities there are that are attached for those communities. So it kind of builds momentum and rolls forward. And that's a very specific piece that many charities from very, very small local mutual aids, grassroots work, right the way through to national, that are a part of at the moment. For Royal Voluntary Service, we continue to do that. We have a whole network of clubs and branches that are very local level, that are needs driven, that are decided by the communities and are run by those communities. So there's lots of volunteering opportunities that are already out there, but I think we can work together to make sure there's even more opportunities for those 12.4 million that Catherine's just mentioned going forward. They don't have to, and I think that this is part of the focus shift we need to do together. It's not just about, we have to make sure they carry on doing what they've been doing through this period. It's to give them opportunities to find their long-term volunteering space and place and what really makes their heart sing going forward. So it's just making sure that we all work together to find those opportunities.
Sam, thank you very much.
So I hope that this morning has been useful. It's shone a light. It demonstrates that volunteering is not a soft option, not something peripheral to everyone's thinking, that it needs to be embedded as part of our planning, both in our state services, our health services, but also in our thinking around how our purposeful businesses engage, how we mobilise lots more volunteering opportunities, both to build a more deeper, more diverse civic society, but also to help people to manage their own health and well-being, both physical and mental. A huge thank you to Dr. Kimberly and to Dr. Alison for their brilliant work, and obviously the two reports will come out, both the literature review and the report that Alison spoke to around the recommendations, and they will come out on Thursday. Thank you to Sam and to Fiona for being part of the panel, and for Fiona for making sure we almost stuck to time. And thank you for everybody behind the scenes. And most of all, thank you to all of you, many of whom have worked with us during the pandemic and who stay with us and keep turning up to these things. It is really encouraging. And I hope that you found it useful and that we'll continue to collaborate effectively as we recover from COVID. So thank you all very much for your time and effort today.